Hello students, welcome to the session on uveitis. Today we are going to see construction of differential diagnosis in uveitis. I want you to remember the first class where we were talking on systematic workup on uveitis, and in that the first portion was mainly concentrating on naming step, where we were talking about history and examination, and we derived a name and we used an old lady's history where there was a 55-year-old lady with bilateral loss of vision in acute nature with bilateral granulomatosis uveitis and exudative and we derived the diagnosis of VKH. This first naming step was followed by naming and meshing step of Nozick. You will remember very well that our patient was compared with the literature and we had list of differential diagnosis. In fact, forming a list of differential diagnosis is also an art in uveitis. This is a very interesting phenomenon. At the end of the lecture, first lecture, we saw a same 55-year-old lady changing 2 or 3 parameters. We had a diagnosis of VKH, sarcoid, ARN. So we were changing few parameters and I was telling you how the diagnosis is changing from VKH to ARN. In a similar way, in this class also, we will be seeing the differential diagnosis with beautiful clinical examples. So you will be able to consider differential diagnosis for set of clinical signs at the end of this lecture. The clinician uses the information gathered from history and physical examination to develop a list of possible causes for the disease that is called differential diagnosis. See, I have a beautiful picture here, you will enjoy this. The original diagnosis is this one and the duplicate diagnosis is the mirror image. And you should be able to diagnose the image from the original. So that is a very interesting exercise in uveitis. And that depends upon various things. The person who sees this clinical case, it depends upon the person who sees the patient. I will give you a beautiful example. My differential diagnosis may be entirely different from a general physician diagnosis. And his diagnosis will be entirely different from a neurologist diagnosis. Don't get confused. With the example, you will come to know what I say is absolutely true. And also, it depends upon when patient present to us. The initial phase, the clinical signs will be very less. You cannot make a diagnosis because information is less. And the end of the disease, most of things will be a scar. You cannot make a proper diagnosis. But when the case is in the middle, you will have enough information to make a diagnosis. Here is an example. This patient has posterior seneca. Just posterior seneca. It's not active. It's a scar. Posterior seneca is a type of a scar. It may be because of HLA-B2 disorder, it may be because of sarcoid, it may be because of TB, it may be because of even trauma. So you will understand that end of the disease and the beginning of the disease, it's very difficult to make proper list of differential diagnosis. So time matters for the differential diagnosis construction also. Here is a beautiful example. A old lady, grandmother, and she is a known hypertensive and known diabetic, and unfortunately she gets a severe headache. And she calls her grandson and says that I have headache. And this grandson every month has to buy antihypertensive and antidiabetic for his grandmother. Unfortunately, he thinks that grandmother is very fussy. He says, I'll take you to the doctor after 2 days. 2 days is last. Then 3rd day, she says, I'm extremely suffering. I'm having headache. I want to go to doctor. Now, he takes her to family doctor. All these things happen in our home also. When somebody has a headache, we take them to family doctor. And family doctor knows that the patient is hypertensive. Hypertension can cause headache. So maybe that drug is not enough. And also, you know pretty well, antihypertensive also can cause headache. Some of the antihypertensives are vasodilators. That also causes headache. So the family doctor checked the BP and it appears normal. But still he wants to change the antihypertensive, thinking that maybe the tablet is not working for her and it is causing headache. So he changes the antihypertensive. But after coming home, she says, oh, I still have headache. I'm really suffering and I'm not able to see. I have giddiness. So now the grandson is a little upset. Now what will we do in our home? Usually when family doctor is not able to make any diagnosis, we take the patient depending upon the severity and the symptom. So we take the patient to neurologist. And neurologists see the disc. Most of the neurologists will not have indirect ophthalmoscope. They will just have the direct ophthalmoscope. Direct ophthalmoscope, this is a picture. And you may see both the disc hyperemic with splinter hemorrhages. You make a differential diagnosis. I'm not going to make a differential diagnosis now. You keep it in your mind. Maybe hypertensive because disc is edematous and it is causing splinter hemorrhages. Maybe hypertension. But remember, family physician recorded normal tension. It was not hypertension at all. At this point of time, what will the neurologist do? Usually they ask MRI. Unfortunately, they don't have transparent skull. We have transparent cornea, so we just see with indirect ophthalmoscope. They have a very, very strong skull. So invariably, they ask for MRI because we know the patient is suffering. And you will agree with me, most of the elderly patients, somehow or other, some infarcts will be seen. Something the MRI will pick up. So for the infarcts, the neurosurgeon started vasodilator. This also you will agree with me. This is routine. This happens every patient. And she comes home and she says, loss of vision and giddiness, I'm not able to see anything. At this point of time, everybody becomes very serious because she's not able to see. Now what will we do? We take the patient to ophthalmologist. I will show you a picture. And this is the picture. Mutton fat capice in both eyes and Busaka nodule and Kopi nodule everywhere in both eyes. You know the diagnosis. It is bilateral exudative detachment is seen in the posterior segment, which we missed in the fundus examination. I showed you fundus examination with the disc. In fact, it had beautiful exudative body. So ophthalmologist makes the immediate diagnosis of VKH. If you carefully see it is bilateral uveitis and he treats with immunosuppressive and steroid even though patient is hypertensive, patient completely gets recovered. In fact, this patient is still coming to me and she has 6/6 vision in this eye. In this eye, she has 6/18 vision and she comes with a beautiful smile. Because she was going after one doctor to another doctor, another doctor, another doctor. Then finally, VKH was confirmed by the ophthalmologist and the treatment worked for her and she came to the good vision. See here, original diagnosis was hypertension. and then it was because they thought it is because of antihypertensive. Then neurologists told that it is CNS problem. The specific diagnosis was derived only after slit lamp examination. Here we cannot blame the general physician, we cannot blame the neurologist. Unfortunately, they do not have indirect ophthalmoscope, they do not have slit lamp. These two instruments are only with us. And the patient did not come to the ophthalmologist first. And you know pretty well, in VKH, the presenting symptom is headache. And most of the patients go to neurologist and they go to MRI, then only the specific clinical sign comes and they lose vision. When they lose vision only, they come to the ophthalmologist. So this, what I told you is, who see the patient is also important. And right time we have to see. And I have seen many ophthalmologists unfortunately miss VKH in the initial stage. When the patient comes with headache, they usually think that it's because of glass variation. They give glasses and send the patient home. But headache has to be treated seriously. 66-year-old lady is not going to read or not going to see WhatsApp, and it is not because of refractive error at all. So we have to see the age and we have to see the way they utilize the vision. And headache, severe headache cannot come after refraction. And many of the ophthalmologists give some paracetamol and send the patient in the prodromal stage. Only in the uveitic stage they recognize. That should not happen. We should never miss a patient in early stage of VKH. We can keep them in observation till they form specific clinical sign, but we should not miss the diagnosis. So how are we going to do our workup so that we don't miss the diagnosis? This is the most crucial thing. Here, history, examination, lab test of that particular patient we do, and complete understanding of our case should be there. Then, complete understanding of uveitis. We have to know everything about uveitis. Unless we know all the differential diagnosis, we cannot make this differential diagnosis. So it is not only our patient and understanding our patient, it is understanding the subject, and then only we can come to the correct differential diagnosis. I show you beautiful examples where our differential diagnosis was absolutely right, where our differential diagnosis was wrong. And I say why it was wrong. And what do we need? Input needed for differential diagnosis, which I have already told you in the first class, demographic details, which often we miss. From which area patient comes to you matter a lot. If a patient comes to, our hospital gets international patients. If a patient is coming from Africa, what disease he will have, and if a patient comes from Brazil, what disease he will have may be different from the disease what our patients have. And we should be definitely having international idea, because medical tourism is very common nowadays. And also we go there and we teach them. We should not be teaching our subject alone, which may not be useful to them at all. So demographic details is very important. Then systemic history is very important. You have seen many times, many cases also, examples. And ocular history, of course, we will take ocular history. And then only comes the slit lamp, fundus, and imaging. So we need everything to make a proper differential diagnosis. It is something like this. It looks like as if we are ascending and then descending, but whatever it is, we have to have everything in hand before we make a differential diagnosis. And it is very funny. Patient will give symptom 1 as the most important symptom, and then the second symptom, third symptom, patient may not even tell you. But that may be the symptom which is very important in your point. I'll tell you an example. There is a lady comes with history of watering and itching. Watering and itching, very common. Very common. And third symptom, she is not telling anything, but she has defective vision in that eye. And if the defective vision is added, the differential diagnosis, which was in the third place, with this 2 symptom, will be coming to second place or first place. But this patient has not told you the important history, and that history is defective vision for 5 years. You come to know about this when you examine. There is a big scar in the nerve, and definitely you know that patient cannot have complete vision. So you check the vision already tested by the nurse, and that says only 636 vision. Then you are surprised, you ask her, you have defective vision in right eye, but you are not telling about that. You are telling itching and watering. She casually says, I thought I have cataract. I thought after cataract I will have vision, so I didn't tell you. But here, patient is not having cataract. Patient is having macular scar. Even after cataract surgery, now at least I'm able to see fundus, I'm able to see the nerve is defective, and this is not going to be removed by cataract surgery at all. So for a doctor who will be doing cataract surgery, this third symptom is very important. Defective vision is more important. So patient may not know watering and itching is nothing, it can be treated with eye drops, whereas the symptom 3, defective vision, is very important, which she thought it is, for quite some time I have, anyway I do surgery and it will come back. But it's not due to cataract, it is due to scar. So that important sign for the doctor, that is the number 1 sign, macular scar. Watering and itching is probably because of meibomanitis, which can be treated with eye drops. So patient will not know order of importance, and we have to know order of importance. Then my first diagnosis becomes the macular scar. So what I will do, I will tell her, teacher, your nerve is defective, there is a scar. Whenever you do cataract surgery, you have to tell this to your doctor. I may be doing or somebody else will be doing. So you have to say that somebody told me that I have a scar in the nerve and I may not get full vision after cataract surgery. This is a very important information, because she may have mature cataract and go to somebody will give good prognosis and do the surgery where patient may not gain the vision at all. So here we will see a scar, macular scar, the differential diagnosis. Here comes your demographics. Toxoplasmosis is there throughout the world. So wherever you see a macular scar with a defective vision, toxo will be your first choice. And if it is India, TB also will be included. You will understand that TB is also very important. Okay, now TB gets included if it is an Indian patient. Onchocerciasis gets included if patient is African. But if you know the patient is from India, you will never make a diagnosis of onchocerciasis, because it doesn't exist in India. So demographics becomes very important. Even though it is rarely used, it is very important. If you ask me, the leptospiral uveitis is very common in Madurai, Chennai, Kerala, Andhra, Gujarat, Calcutta. But leptospirosis is never seen in Chandigarh or Delhi. A metropolitan city will not have walking cows and cattle on the road. Only in villages, people live in close contact with animal. So leptospirosis is common in villages or cities where people and animal live together. So demographic becomes very, very important. Now, the same patient with defective vision comes with two different symptoms, red eye and floaters. It's not watering and itching, okay? Red eye and floaters. And we look for the sign and there is a new active lesion near the old scar. You remember the last class? It has a beautiful active lesion on the old scar. You immediately made the diagnosis of toxoplasmosis. Here also, patient says floaters and there is a new active lesion, your diagnosis is toxoplasmosis. Isn't it beautiful? Something gets added and your healed scar becomes toxoplasmosis. It gets confirmed. Of course, you will do lab test and you confirm with the lab test. That is a different story altogether. That will be a different class also. Now, if it's the same patient with defective vision, instead of red eye and floaters, he comes with pain and floaters. And you examine, systemically patient has developed pulmonary tuberculosis. Then this toxo will become second differential diagnosis and TB will become first differential diagnosis. So, with the symptom, when new clinical sign gets added, your differential diagnosis gets modified. Isn't it something like kaleidoscope? No? Every moment it changes. The differential diagnosis changes with the kaleidoscopic picture. And that is a beautiful experience. And this makes life very thrilling. With every patient, every corner of the road, you will have a different differential diagnosis. And you should be very clever to pick up. That is why I told you we need eagle vision. Now we have beautiful examples. I am the student and you are my examiner and you are telling me unilateral uveitis. And patient with pain, redness and refer to uveitis clinic. It is too less information. Only one information you have given. These are the possible list of differential diagnoses. I am in such a poor state. No? Will I say traumatic? Will I say fuchs with glaucoma? Only fuchs with glaucoma will have pain and redness. Simple fuchs you will never have pain and redness. So maybe it is traumatic, maybe fuchs with glaucoma, maybe herpetic muscular. It can be anything. When you give only one information, I cannot make a diagnosis. Okay, now you are sympathetic with me. You are adding one more information. You say this patient has unilateral granulomatous inflammation. Now I am in little better state. See, I can rule out HLA-B27 because that is non-granulomatous. Fuchs is also non-granulomatous. And VKH and sympathetic ophthalmia are bilateral. And here you say it is unilateral. So this is also unlikely. But still, my differential diagnosis is not very short. Unilateral granulomatous may be viral, TB, sarcoid, traumatic, syphilitic. You will agree with me. All these things are possible. So I expect some other information from you. So my differential diagnosis gets shortened. You are very kind enough to say acute anterior. You are adding one more information. But unfortunately, my differential diagnosis is not getting smaller. The same differential diagnosis which got eliminated because it is acute anterior, whereas VKH and sympathetic ophthalmia is pan-uveitis, not anterior uveitis. So this information is not that helpful to me. So I wait for another information and you are giving me old age. Now, many things disappear. In old age, acute anterior granulomatous unilateral uveitis is lens-induced or viral. Almost always. Because sarcoid in this patient at old age and that to male, it will not happen. And TB is possible, but unilateral acute anterior uveitis, you know TB and sarcoid is chronic. Acute will not occur. So lens-induced viral is the first, but rarely you can have TB sarcoid as acute. That you will add later. If you confirm that it is not lens-induced, not viral, then you will look for other possibilities. Now you give me a picture of slit lamp of this man. So now we know beautifully that it is a leaking mark ganglion with hypopion, so it is only lens-induced uveitis. So as you add information one by one, my differential diagnosis becomes small, and finally it is a single diagnosis, unlikely viral. It is not TB, it is not sarcoid, it is not viral, it is only lens-induced. Isn't it beautiful? It is only you are collecting information and adding information to the list. Now, if the same patient has chronic uveitis instead of acute, chronic uveitis, and I am telling another example, the same age group, chronic bilateral anterior uveitis, it's unlikely to be lens. Because lens-induced uveitis will always make pain, patient comes to you immediately, it is acute in nature. But an old man living with just defective vision, he doesn't even know that he has uveitis, he is almost asymptomatic as far as uveitis is concerned. Bilateral, chronic, anterior uveitis in the older man may be leprosy. Leprosy will never cause pain. And few KPs will be there. And iris atrophy will be there. So with the slit lamp, this is not showing any iris atrophy. This is not showing any chronicity, but instead of it is showing acute nature of the disease in the form of hypopia. So now you know that medical history and ocular examination to develop a possible list of diseases, that is called a differential diagnosis. I think you don't have any doubt in this session now. I have a beautiful case. This pediatric uveitis. Just in contrast to old man, I have a child, beautiful child. And you say that it is pediatric uveitis. I am a poor student and only one information. So I think JAA, parasitic, traumatic, herpetic, intermediate uveitis, leukemia, because in children, leukemia can come as uveitis. But in old men, it will not come as hypopion. But beautifully, we can rule out lens-induced uveitis because this child will never have leaking mark ganglion. This child will never have leprosy. Leprosy takes 10-15 years to form ocular signs. This is not fuchs uveitis. At least few things I have ruled out because you said pediatric uveitis. But I cannot make any definitive diagnosis and my differential diagnosis is bigger. I expect some more information from you and you are kind enough to tell that patient has arthritis and joints are swollen. Immediately I jump into the conclusion that it is JRA, juvenile rheumatoid arthritis. But will he be right? I have not done any ocular examination. You have not given me any information about the eye. I cannot jump into this conclusion at all. I may be wrong in this differential diagnosis. Then you say bilateral granulomatous. JRA is a non-granulomatous, bilateral non-granulomatous. Here you have a patient, child, pediatric uveitis, arthritis, bilateral granulomatous. What is your differential diagnosis? Everything gets changed. You rule out JRA. JRA is very, very, very common in children. Very common in children. But unfortunately, our patient is not having JRA. She can have sarcoid or Bloss syndrome, TB, VKH, viral. Sympathetic ophthalmology she cannot have because she didn't have any trauma or surgery. If you see carefully this picture, granulomatous KPs are seen very well. So bilateral granulomatous, we have all this differential diagnosis. So still I expect some more information from you. And there are conjunctival granulomas. Conjunctival granulomas are seen in sarcoid. So we did biopsy really in this patient, and we proved that this patient is a sarcoid patient. So now we have enough information. Pediatric granulomatous with joint pain, even though the patient has joint pain, it is not juvenile rheumatoid arthritis because she had granulomatous uveitis and she had conjunctival granulomas. In one another talk, I show you the same girl with so many sarcoid granulomas all over her body. So this patient, now combination of clinical signs has given you the diagnosis. So you need history, you need slit lab, you need fundus, and you need systemic signs. And in this case, even though the patient had joint pain, because the child comes with uveitis with the joint pain. And in fact, you will not believe this child was not walking when she came to me first. The mother was carrying the child. Every joint was painful. The child had such a painful face. And after that, after treatment with steroid, she became so beautiful. I have that picture in another talk. You will see. Just because she had conjunctival granuloma and granulomatous uveitis, rule in sarcoid and rules out JAA. Okay, now she is taking part in games and she's grown up. She has finished her schools. She has gone to college and she's absolutely normal. Now I'm going to tell you a very, 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 very interesting case with the list of differential diagnosis and with the emotional factors. This lady, 22 years old bride, she's going to get married in a week time, and she comes with bilateral acute vision drop. She is coming with her future bridegroom. I was so tense because if something goes wrong, the marriage will get stopped. I want her to get married. And the moment I know that she is going to get married, I thought, oh my God, it is bilateral loss of vision. So we have to look at this patient with carefully, and we had the history. That is sudden, painless, bilateral drop in vision only for a week. And she was taking for acne. You see the picture, there are so many acne. So she was taking treatment for acne in the form of creams and capsules, minocycline and skin light ointment. And she had multiple skin cream application for facial whitening. This is nowadays very, very natural. Girls go to beauty parlor and they want to look bright. And then this is a part of her pre-wedding preparation. When I asked other history, the reason I asked all this history is she was a little dark girl, but her face was shiny, which was very abnormal, which was very not looking like the body was different and her face was different. So I asked, what have you applied on your face? She told, as a pre-wedding preparation, I'm going to beauty parlor, and they gave me some ointment and I'm applying. It was looking so different. Then I asked the history of lotus. There is no history of lotus. So it is not anterior uveitis, it is not intermediate uveitis, because those things are common. Lotus is common in those things. There is no photophobia. So it is not anterior uveitis. There is redness, there is no redness, there is no tinnitus, no headache. So there is no clue for the diagnosis. And I asked more about skin light cream. I went into the literature and saw, and this is memetrazole is a steroid. And see her right eye, it looks like she has some exudative RD. It is very bright. And when I see her vision, it is very much less in right eye. It is 660 and 618. And when I see the eye also, this looks white, so maybe exudative RD. Now you have to tell me the clinical picture. Both eye vitreous is clear. Right eye is hyperemic disc. Disc is red, more red. It is not pink. And this disc is edematous. Multiple packets of exudative RD. Here is a multiple packets of exudative RD. Inferior exudative RD, which is not captured in this picture. And in addition, she has macular star, and there are some old scar in the periphery also. You want to make a differential diagnosis? Bilateral exudative RD again, like yesterday's patient. Bilateral exudative RD. There are some difference from yesterday's patient because this patient is young, and this patient has used steroids. Disc is anyway hyperemic. So what we did is, we made two diagnoses possible. CSR, probably because of steroid in her facial lotion. You know pretty well, CSR can come in anxious patients. This patient has every reason to be anxious. She's going to get married. She's a software engineer working in Chennai, and bridegroom is from Madurai. She has to change her job. She have to leave the job or change her job, and she's going to get married. So she's obviously anxious, and she has used a lot of steroids. And you know, there are so much of literature support. Steroid can make the CSR worse, make the CSR into exudative RD. So our first possibility was we were so biased with the steroid, so we thought it is steroid and CSR is the first diagnosis. Second diagnosis, because there was skin bleaching, VKH. Like yesterday's lady, VKH syndrome. And we ourselves have published VKH after cutaneous injury. I'll show you a beautiful example here. I have 3 ladies who developed depigmentation at the place of bindi. It is because of contact depigmentation, because of a particular chemical, free para tertiary butophenol in bindi. This gum of the sticker bindi causes this white vitiligo. I am telling all the ophthalmologists, many of our patients come with a very faint vitiligo at bindi site. In those patients, you have to ask them to change the bindi. They cannot use this gum anymore. Not everybody develops VKH, but it is very ugly to have a vitiligo patch in the face. So this particular patient, after developing skin lesion, she developed VKH. This we published as early as 1999. So we thought this could be VKH syndrome after her multiple application of bleaching agents. Okay, we have CSR and VKH as the differential diagnosis. And you know pretty well that we do complete blood count in every case. VDRL TPHA, ACE, PPD, not because this patient is suffering from TB, because we may be starting immunosuppressive and steroid. So we routinely do PPD for every case. Then FFA and ultrasound specifically for this patient. You will agree with me because we want to see CSR or VKH. So FFA is most important. Here comes your FFA. It is neither supporting VKH nor CSR. You don't have multiple leaks, starry sky appearance, smokestack appearance. There is no clue for VKH and CSR. Oh my God. This is only pulling of dye in the exudatory wall. This is not helping me. And there is a old scar, and that is quietly sitting as the old scar. It is not even leaking. Then I do ultrasound. To my surprise, ultrasound comes as a solitary lesion here. In VKH, you will agree with me, choroid will be thickened like this. Diffuse, it is diffuse. So the whole choroid will be thickened like this. It never presents as solid granuloma. It came as a shock to us because it could be a cancer. It could be masquerade syndrome. Maybe she has cancer somewhere in her chest or abdomen. Because in this age, I have one more patient, a bronchogenic carcinoma with a metastasis. So I was so shocked. By this time, it is only 4 days for her marriage because we are doing one investigation after another, and we have lost 3 days already. And there is a solitary nodule. I don't want to tell her husband that it could be carcinoma. Of course, it could be TB also. So, with reservation, we asked for CT chest, CT abdomen, and CT brain. Because for both to work on TB and also for masquerade syndrome, you need to do all those things. By God's grace, it was tuberculosis. It was not cancer. It was not masquerade. It was not metastasis. It is only tuberculosis. So, what we did, we gave steroid and ATT immediately. If you see this CT scan, see here, there was lymph node. Tubercular etiology more likely than sarcoidosis because of mediastinal lymphadenopathy. Mediastinal lymphadenopathy will not cause cough. It has been silent. And PPT by the time came because it was 3 days. And it was positive. So we have started feeling much comfortable. It is only TB, Mantle is positive. We started immediately for drug, and also we started very heavy dose of steroid because we want her to have better vision, though not complete vision, on the day of marriage. It's only 3 more days. So we added steroid. The lesion started healing. She had 618 in both eyes. She was so happy that she got married on that day, proposed day, and in 4 weeks, the solitary granuloma is gone. It has become absolutely normal. And patient is comfortable and had vision of 20/20, absolutely normal vision in both eyes. She's still coming to me. Here, one very, very important clue. See, there is a old scar, which looked like an innocent scar. And there is a macular star. If you think carefully, neither VKH nor CSR will have this scar and macular star. So if we have given importance to this, we might not have had differential diagnosis of CSR and VKH. Then I asked the patient whether you had eye problem at any time in your life. She said, yeah, 2 years back I had a minimal problem with my left eye, but it disappeared on its own. That is the reason for this scar. This was tuberculosis from the beginning. And this got exaggerated because of her anxiety for the marriage. She had both the tuberculosis. So this scar was more important. We should have seen these two. Then we could have added TB in the first list itself. We will not be worried about cancer. So now you will agree with me. The clinical picture is variable depending upon various factors. It is stage of the disease. In that particular lady with the old lady with VKH, prodromal stage was missed. So stage of the disease matter a lot. Severity of the disease. In HIV patient, biggest toxoplasma lesion will not have VJ cells. Toxo lesion size we know. That will be bigger in HIV patient. So severity of the disease gets changed depending upon other associated diseases. Whereas a diabetic patient will have a carbuncle and will have endogenous endophthalmitis more commonly than other patients. So severity of the disease varies depending upon other diseases the patient is suffering from. Immune status of the patient. Some patients will be hypersensitive. So in leprosy patient, if the patient is hypersensitive, the patient develops tuberculoid leprosy. If the patient is allergic, they develop lepromatous leprosy. So immune status of the patient varies. The clinical picture also varies. Virulence of the organism. This is very important. I have a beautiful picture in another class, maybe next class. The Pseudomonas causing scleritis. Pseudomonas, you know, it is a very virulent organism. The scleritis is so big and pus is pouring down. So virulence of the organism matter a lot. Same time, fungal scleritis will be looking little different. You know, from fungal corneal ulcer to bacterial corneal ulcer. So you will agree with me, virulence of the organism, type of the organism, everything changes the clinical picture. Other diseases, I gave you example of HIV and diabetes. And other diseases, in fact, patient will be receiving drug for other diseases. Unfortunately, the drug will cause ocular problem. Patient will not bring you the slip because that is given by different doctor for different disease. I tell you a very, very important information. I had a patient of endogenous endophthalmitis. We were asking all the questions which the textbook says. And nothing, she never had IV infusion. She never had a urethral catheter. She never had abdominal surgery. She had never had any other problem. She comes with endogenous endophthalmitis. When I was repeatedly asking, she told she's taking psychiatric treatment for depression. For depression, they give paroxetine, which can cause urinary retention. That tablet has caused urinary retention and urinary tract infection. And when we grow the organism by culture of urine, it shows candida. And we do surgery in the eye, candida endogenous endophthalmitis is there. So other diseases alone is not influencing. The treatment of other diseases also can cause eye problem. It may be associated with that. And paroxetine also causes macular edema. Unexplained macular edema in a middle-aged woman who looks upset maybe you have to ask, are you taking any other tablet? That history is very, very important. It is a history, but it's very, very important. Because we will be treating macular edema and they will be treating with paroxysm. When will the patient get rid of the disease? Unless she stops paroxysm, you cannot get rid of macular edema. So history is important. Treated or not, this is what I am telling. The same patient, if she has been treated by another doctor with steroids, the picture will vary. Infectious disease will become worsen, autoimmune disease will become less worsen. So treated or not also important. See, when you see so many pictures here, we know pretty well this is the same hand, just making some vicious movements and bringing a different shadows every time. Will we be confused? No, we will not be confused. We know that this is an artistic game where fingers remain same. It's only shadow is different. Like that, because of all these factors, the disease look different, but the uveitis person should identify the hand, not the shadows. I will give you another example here. Will you ever get confused if your Western friend comes in Eastern dress? Never. The American lady coming with saree, will you say she's from Madurai? No, not at all. You will know that she's a Westerner. Like that, if you are very, very clear in your understanding uveitis, your differential diagnosis will be appropriate. And it is very, very easy to make differential diagnosis and final diagnosis. This lecture will be followed by lab investigation, where your differential diagnosis and top diagnosis will have the most appropriate lab diagnosis. Then we will go for treatment part. So students, hope this session is useful to you. Thank you.